All right. Hi, everyone. Welcome to today's all-member National Policy and Partnership Town Hall. It's our rebranded name since while COVID will continue to be a hot topic, it won't be our only topic. And I see folks are being admitted, but while we're waiting for that, next slide, please. We can do some housekeeping. I'm Amy Dodd with AMCHP. If you have any technical difficulties, though, please reach out to Lauren. Her email is at the bottom of this slide. We will be recording this, and we really hope you'll take time to fill out the evaluation at the end. Thank you. Next slide. So to review our agenda for today, we're actually going to start with a partner presentation by Mei Kwong from the Center for Connected Health Policy. We will have updates from our federal partners at HRSA and CDC, and we'll end with the AMCHP policy update. Next slide, please. So I will turn it over to Mei to get us started.
Thank you, and thank you for having me here today. I've been asked to talk about what telehealth will look like in a post-public health emergency environment. Next slide, please. Before we get started, I always have to start off with a couple of quick disclaimers. Please know any information I provide today is not to be considered legal advice. It is strictly for informational purposes. If you do want to form a legal opinion, please consult with legal counsel. And also, if I happen to mention company or show some type of product or a picture of a product, know that neither I nor CCHP has any type of financial interest, relationship, or affiliation with such company. Next slide. Quick background about CCHP. So we actually started off as a California telehealth policy organization in 2009 as a program underneath the Public Health Institute. An opportunity to become the federally designated National Telehealth Policy Resource Center through a grant from HRSA became available in 2012. CCHP applied for that, and we got that, and we've been serving in that capacity ever since. What that means is we receive federal funding to provide technical assistance, basically to people who have questions around telehealth policy. We were originally meant to really service the other telehealth resource centers that are underneath the same grant program, but we kind of opened it up to basically anyone who may have a question on policy, whether they be policymakers, lawmakers, or like health plans or providers, or even like during COVID, we actually received quite a few questions from consumers and patients regarding telehealth as well. We also work with a variety of other funders and partners in the state and federal level. And we also act as the administrator for the National Consortium of Telehealth Resource Centers, which is the other telehealth resource centers underneath the same program CCHP is, with funding from HRSA. We decided a couple of years ago to come together and pull a bit of our resources to work on common projects and collaborate more closely on things that, you know, have more of a multi-regional or national reach, just in order to like cut down on inefficiencies and duplication. And CCHP also acts as a convener for the California Telehealth Policy Coalition, which is a group in California that we started that is interested in advancing telehealth policy in the state. Next slide, please. So this next slide is kind of like your very general high-level overview of the changes that took place in response to COVID when you're talking about telehealth policy. Now, as I said, this is very, very high level, so there's like a lot of intricate details underneath there. But basically, I wanted to point out sort of like what are some of the areas that telehealth policy impacted during COVID-19 that needed to be addressed. And as you can see, there's actually some similarities between what happened on the federal and the state level, simply because a lot of the existing policy around telehealth touch upon these common issues. So such things as what services can be covered if you're using telehealth, what provider can provide that service and get reimbursed, questions around licensure, questions around prescribing, questions around like privacy. So you see some commonality there. And you also see some things that are maybe exclusive to either the federal level or the state level as far as like control over what they're doing the policy, such for example, licensing that's in the state's area to really do, whereas prescribing of controlled substances, it's more of a federal issue there. So this is kind of like, you know, your very sort of like high level overview of what happened. Next slide. We're going to get into like a little bit more detail of what actually some of these proposals were, some of these temporary proposals, and what's going to happen once the public health emergency is declared over. So we'll start off with federal. Next slide. And on the federal level, I've broken it out. Again, this is like very sort of high level, but just to give you an idea of like sort of just to keep it organized, the chunks of where policy was impacted or where there were temporary waivers or changes in response to COVID for telehealth. You can break it into like three sort of major areas. A lot of other things happened, but these were kind of like your major points here. There was the Medicare program where there were waive statutory requirements and also a series of administrative changes. So with Medicare and telehealth policy, there's stuff embedded in federal law where you would need congressional approval or action in order to like change it in any way. But there's also stuff that the Center for Medicare and Medicaid Services, or CMS, can do to like change the policy where they don't have to wait for Congress to act. They can go ahead and do it themselves. And what we saw with Medicare during COVID-19 is that there was a combination of both of that happening. And there's now been also a combination of that happening that's going to impact what happens in a post-PHE environment. Prescribing, there was also impact on like prescribing mainly controlled substances. So prescribing controlled substances when you're using telehealth is controlled by federal law. And there is a series of exceptions where you can use telehealth where the telehealth provider has not seen the patient in person, but they can still prescribe via telehealth. And they're very narrow exceptions, such as, oh, the patient is in a DEA licensed facility when the telehealth interaction takes place, or the patient is with a DEA registered provider when the telehealth interaction takes place. They're very narrow exceptions. And one of those exceptions was if a public health emergency is declared, then you can go ahead and prescribe via telehealth a controlled substance and not have that telehealth provider meet that person, that patient in person before. So that was another exception that kind of automatically kicked in because it was something that existed in federal law already. And then there was HIPAA, and this is sort of an administrative action that you will see in that the Office of Civil Rights, which oversees HIPAA, they said they would exercise discretion in like how HIPAA was treated when you were using telehealth. So this basically like allowed different platforms such as like FaceTime and texting to be used, which you normally wouldn't use in a non-PHE environment to provide services via telehealth. So these are sort of like the major changes, temporary changes that were in effect to deal with COVID. Next slide. So what's going to happen when the public health emergency is over? So during the past 2 years, there's actually been some shift to making some things permanent, or at least some things that would last beyond the public health emergency for a period of time. And this has been done mainly around the Medicare program. So that first column, that first block there, and it's been mainly done through either administrative way or through a legislative way. So a legislative way, there's specifically been 2 bills passed, and they have like the common name. So the Consolidated Appropriation Act, there was one passed in December of 2020. And then there was the budget bill that was passed recently, just a few months ago, for the 2022 budget, which included some telehealth policy in there to make certain things permanent or to give us an idea of what happened in a public health emergency, post-public health emergency environment. So the first one was Consolidated Appropriation Act, where they permanently expanded the use of telehealth when you're providing a mental health visit. And by doing that, by removing what's called a geographical restriction. So without the public health emergency in Medicare, you needed to be in like a certain location, both geographically and the type of site. So the Consolidated Appropriation Act expanded that to allow more places, such as the home, to be an eligible site, but also remove the geographic requirement if a patient was receiving mental health services. However, they put a lot of caveats on there. So one of the big caveats was, well, there needed to be an in-person visit with the provider, the telehealth provider, prior to those telehealth visits starting. So there were like certain conditions added to it as well, but it was a permanent change. So that means if the public health emergency was declared over, you did have this expansion of providing mental health visits that will be covered by Medicare, but there are a lot of sort of caveats attached to it. The Budget Act that was passed in 2022 that contained telehealth provisions basically was an extension of certain things or a delay of certain things. So what it said was it would extend some of the temporary COVID telehealth policies 151 days after the public health emergency is declared over. So there's a bit of a grace period, about a 5 months grace period for certain things. Now, they did not say all of the telehealth temporary policies would be available in those 151 days. They only said some of them, and they were basically the allowing of the geographic restriction and allowing certain providers such as OTs, PTs, speech language pathologists, and FQHCs and RHCs to continue to provide services via telehealth underneath the Medicare program and getting reimbursed. What was not on there was the what I talked about in the previous slide, such as like the HIPAA change or the prescribing controlled substances. So it did not touch upon all of the waivers, it's only touched upon some of them. Now, administrative changes that made permanent changes to like the telehealth policy were through something called the physician fee schedule. So for those who aren't familiar with it, Medicare comes out with proposals every year called the physician fee schedule that will be policies for the following year in Medicare. And this is where a lot of like telehealth administrative changes happen as well. So what they did was basically they implemented what was required of them with the December 2020 Consolidated Appropriation Act, but they also said we are going to allow audio only to be used for mental health visits as well, if certain conditions are met. And we're also going to allow FQHCs and RHCs to use telehealth synchronous, that's the live video, and audio only for a mental health visit, because, and we're doing this because we're going to redefine what a mental health visit means for these entities. So for those who are not familiar, FQHCs and RHCs are not eligible providers in a non-PHE environment to be a distance site provider underneath the Medicare program. That is like something that's in federal law, that specific list of who can be a provider, and FQHCs and RHCs aren't on there. They were temporarily allowed during the public health emergency. CMS can't change that. That's in federal law. They can't make an administrative change, but what they can do is redefine what a visit means for these entities, and that's what they did. So for mental health visits, they added this technology component to it, saying that they can do it through these technologies because that's just a mental health visit that they're providing. That's a very important distinction because then that's not cataloged as telehealth for these entities. But all of this can only take place, these sort of administrative actions for mental health, allowing them to use audio only, allowing FQHCs and RHCs to provide mental health visits through technology if certain conditions are met. And one of those conditions is the having a visit in person that we saw was similar in the Consolidated Appropriation Act. So the Budget Act of 2022 put a pause on there on these conditions as well. So they said, if the public health emergency is declared over, these conditions, these permanent policies that CMS put in place for mental health visits, there's going to be a pause on that as well. We're not going to require that as well during that 151-day period where we allowed a temporary extension of some of the COVID policies that have not been made permanent yet. So there's like this little temporary extension, this little grace period here where you don't have to meet these new permanent policies. And also there's like continuation of some of the temporary extensions for the COVID policies. It's all really complicated, and I know that, but this is kind of the policy environment that they've given us with these recent changes. Additionally, there was a temporary extension for some of the eligible services. So during COVID-19, CMS put on, allowed some services to be temporarily provided via telehealth. They aren't on like the permanent telehealth list for reimbursement underneath Medicare. And they said like some of those services we're going to allow to stick around until the end of 2023. So they're not actually underneath that 151-day grace period unless for some reason the PHE like extends out further. They have like a set date now. They said like they're going to stick around at least till the end of 2023. You can still underneath the Medicare program provide these services via telehealth. And that was to give CMS time to kind of gather more sort of like data and evidence to see like, should we shift it over to the permanent list? Next slide. A lot of information, just one slide, I know, but that's where we are. I talked about this earlier. So the 2022 budget did allow, again, that temporary extension of 151 days and then delaying like some of those administrative changes. The couple things to keep in mind. So we know PHE was extended last month to April 13th. So that takes us out to April, May, June, to around June-ish for like another 90 days. The secretary needs to renew it every 90 days in order to keep it active. And we also know that the feds have said that they would give the states 60 days notice of like when they're ending the public health emergency. I'm not quite sure if that means 90 days and additional 60 days notice, or if they mean like 30 days into a 90-day renewal period. We're going to warn you that in 60 days, the PHE is going to declare it over. So that's also one thing to keep in mind. I've heard two different things. I've heard we may see the end of the PHE by the summer being declared over. And I've heard others say like, no, I've heard it's supposed, they're thinking of extending it through the end of the year. So we'll see what happens if there's like another extension anytime soon. Next slide. State policies and what's going on at the state level. Next slide. So the states right now, I don't know if you're aware of it, CCHP just released like our 50 state update for the spring. What we're seeing is what states are doing is that they have already been making decisions on permanent policy ever really since last year and a little bit before that. So they have been solidifying what they are keeping around, at least for now, for in a post-PHE environment. And we've seen some shifts here in like the Medicaid program on the fee-for-service side. We've seen increases in store and foreign rural patient monitoring, expanding those policies and making them permanent. But most interestingly is we've seen the biggest gains is regarding audio only, which is really important, I think, for the population that this group like really serves here as well. Because one reason that audio only was important during the pandemic was that not everybody had access to telehealth. So they were able to allow audio only to be used for those folks who maybe have issues with like, trying to connect because they don't have good enough bandwidth, they don't have equipment, etc. So audio only was like really the only way to maybe engage with their providers. So for a lot of states to make that permanent policy, I think will help those populations that may have those troubles. Maybe they're of lower income or they're in rural areas or areas where they aren't able to like access connectivity as easily, or they're maybe just more comfortable doing it via audio only as well. One note though about the audio only policies, there's usually a lot of caveats for them. There's very few states that have a blanket like, well, we're going to allow audio only for everything that you can possibly do it for. A lot of them do say like, we're only going to allow for mental health visits, similar to what we saw with CMS on the federal level. Or they may say, it's only for like these couple of things as well too. Next slide. Private payer laws are another thing that happened on the state and what we saw during the pandemic. Really to the credit, I think, of a lot of insurers, they automatically allow telehealth to be used more widely during the pandemic without being ordered by the state or anybody to do that. But a lot of that's being rolled back. So what are they doing now? And it's like kind of a mixed bags on what's health insurers are doing as far as keeping things permanently. But states have been moving to enact laws to adjust for that. So we're definitely seeing more states enacting laws to really make sure that if you use telehealth, that provider is going to get paid the same. That number, we have like 21 states that now have some specific payment parity language in their telehealth private payer laws. Before the pandemic, that was like not a double-digit number. So that's been a significant shift that we've seen over the past 2 years. Next slide. So what do we expect to see from states? Well, in 2021, there were 47 states that passed 201 bills related to telehealth. These were kind of like the most popular things around. The issues that they addressed was private payer reimbursement, Medicaid reimbursement, and cross-state licensing. Cross-state licensing has been a big issue during COVID-19 when you're talking about telehealth. We're also seeing like policies impacting specific professions. So one thing before the pandemic was there was sometimes certain professions that were limited in their ability to use telehealth just because of the way the reimbursement policies were set up, such as OTs and PTs. So we're seeing more specific language to allow that, or more sort of guidelines on how they're supposed to use telehealth. And then online prescribing is also like been another sort of hot issue to address as well. Next slide. So what can we expect to see as far as legislative trends on the state level for this year? Really, basically, states like the feds, if they haven't made the decision already, they're going to start finalizing what it's going to look like in a post-PHE environment. And so far, they have been kind of mirroring what they were doing in 2021. It's like making decisions in their Medicaid program, making decisions around private payer changes. Interestingly, there's been like more direction about documentation and record keeping. So before the pandemic with telehealth, it was basically kind of a broad thing like, well, you would do the same thing you would have done in person, but now there's been more explicit of like, we want you to collect X, Y, and Z. And then like more sort of the explicitness of like what they would consider are telehealth standards for various professions. So guidelines on how to use telehealth. So those are the trends that we're seeing so far. How that impacts your population that a lot of you probably serve and maternal and child health programs are a lot of the reimbursement policies there, and allowing like certain professionals to be able to use telehealth to provide services. Again, going back to like those allied health professionals of OTs and PTs, but also where they can do the services too, and the modality that they can use, such as audio only. And a lot more what we're seeing, it wasn't on these slides, but what we're seeing is like more openness for services to take place beyond sort of like the doctor's office or a hospital and clinic, such as like allowing them in the home too. So, and I think that's it on my slides. That was a lot of information to give you. This is our website. You can go ahead and check that out, as well as we have a newsletter too, if you're interested.
Awesome. Thank you, May. You covered so much information in a short time, and all of it was really important. I know that you have to leave in a few minutes, so we want to open up for questions from May just for a few minutes if anyone has any. And I'll just start by asking, what resource would you point people to for more of the like direct-to-consumer questions that they may have about accessing certain services via telehealth?
So there's been like a lot of places, like a lot of different organizations that represent different populations that have actually come up with like their own sort of consumer guidelines as well. So if it's a specific population, I would say like, you know, perhaps look at like those organizations in place for them. For example, maybe it doesn't apply to this group, but they're the first example I can think of the top of my head, like AARP has been very active in the telehealth field as well in telehealth policy. So they have created a lot of like consumer facing information as well. CCHP does have some of that information on our website, but I would also encourage folks to reach out to your regional telehealth resource centers. So I mentioned them earlier, there are 12 regional telehealth resource centers and they cover specific states. And the reason, you know, not only because they're like our sister telehealth resource centers, that they're really good to reach out to is because they cover specific states. So they have more of that knowledge and that relationship with the community out there, and they can kind of tailor the needs to meet those specific communities. So I would encourage you guys to reach out to them as well too.
Great, that's helpful. And I know that there's links to all of those on your website as well.
Yeah, and there's like, if you want a little bit more general information, the federal government also created a telehealth website. It's hhstelehealth.gov, I think is like the URL as well too. And there's some consumer facing thing. It's a little more general. That's why I suggest Telehealth Resource Center. But if you are looking for a bit more general information, there's some general information there too.
Awesome. We'll give folks another minute. Do you have any questions? You can either ask them in the chat or unmute yourself and ask.
And Amy and Lauren have my email address too. So if the question comes on afterwards, you think of something after I'm gone, feel free to like forward it to me in email.
Great, thanks so much. All right, well, we won't keep you any longer than we need to. So thanks again, May. It's always a pleasure partnering with you. And we'll go to our next presenter, and that will be Chris Dickton on behalf of the Maternal and Child Health Bureau.
Thanks so much, Amy. It's so great to be here with everyone today. And I'm just delighted to be able to give the updates from the Maternal and Child Health Bureau. Next slide, please. So on April 28th, we concluded our three-part virtual partnership meeting series. And I want to thank you all for your active participation and engagement across the three meetings. During that time, we discussed the water systems change framework and how it can be used to guide health equity work. And what was really exciting was the highlight of the breakouts led by states in sessions 2 and 3 to hear about the individual state equity journeys and the ways in which we're advancing equity internally as well as with our partners. And I want to thank AMCHP in particular for partnering with us on this meeting series. All the recordings and information is available on the AMCHP website, which is linked on the slide. And then speaking of AMCHP, we are excited about the upcoming AMCHP annual conference. A listserv message went out yesterday from us at the Bureau outlining the various MCHP sessions taking place on Monday, May 23rd. This includes the regional office hours with Dr. Warren and Laura, the SSDI grantee meeting, and then the skills building session that we'll be holding for the Title V block grant directors and coordinators. Please look at and reference that listserv message or reach out to your project officer if you need details on any of these sessions. Also, over the weekend, HRSA launched a new national maternal mental health hotline. This hotline provides 24/7 free confidential support before, during, and after pregnancy. We're really excited about this development, and it was piloted early in the spring, and now it's open nationwide. More details can be found on the MCHP website linked on the slide. Next slide, please. Just as a reminder, Title V information system is open as April 1st, and the learning labs are going to continue over the next months to support you in your preparation for submitting this year's fiscal year 23 application and the 21 annual report. The due date is August 12th. Review meetings are being scheduled starting in September and will be going through mid-December using the schedule that we've used the past couple years. And then resulting summary statements will be distributed from the beginning of October until February. So if you have any questions, again, the key person to reach out to is your project officer or regional consultant. Next slide. So lots of things happening. There's NOFOs on the street currently that MCHP is supporting, and these funding opportunities are due between now and August. We have the Transforming Pediatrics for Early Childhood, which will fund up to 4 cooperative agreements for May 23rd, due May 23rd rather. There's the Community Health Worker Training Program, which is a very exciting prospect of training community health workers. There's the State Maternal Health Innovation and Implementation Program, which is building data capacity to expand the State Maternal Health Initiative innovation programs rather. And that's due June 13th. This is really exciting because it's going to help support data surrounding the AIM bundles. And of course, something that's very important to us in the Division of State and Community Health, the State Systems to Develop Initiative has opened up and is due at the end of August. It's due a couple weeks after the block grant are due. So we're looking forward to seeing those applications come in. So that's a lot in 5 minutes and a lot of practical information. But what I want to spend this next 5 minutes on really is talking about an issue that has become really evident and become the talk of the press and certainly the talk of us both in the state and the federal arenas, and that's looking at the shortage for infant formula. So next slide, please. I'm sure most of you are aware of the formula shortage impacting our country. And so wanted to take an opportunity to share a few key messages for Title V and for families on formula needs and ways to move forward to trying to address this crisis. Next slide, please. So the background is, during the pandemic, and this started in the fall of 2021, there was reports of temporary and isolated infant formula shortages. And it was reportedly due to persistent supply chain problems around the world. And the problem was exacerbated this past February when Abbott Labs, one of the 3 largest FDA-approved infant formula manufacturers, announced a massive recall on their Similac, Alimentum, and Alicare formulas. And compounding that was, it looked as if stockpiling of the formula by concerned families might have also contributed. But as of April 3rd, 31% of the most popular baby formulas products were out of stock at retailers across the country. Next slide, please. So we're looking at what we can do to help support and address these issues. We know that this is a conversation with governors and with governors with state Title V programs, among others. So some of the key messages for parents around formula recalls and shortages, do not feed your baby or toddler recalled powder formula. It's important to check and see if you ever have a recalled formula by reviewing the codes on the bottom of the package, visiting the company's website, calling the manufacturer. Do not throw away the recalled formula. Return it to the store for a refund or exchange. Call the company. Next slide, please. I think one of the important things is that we're sharing to parents is talk to the medical provider or your WIC clinic if your regular formula is not available, and you need recommendations on other ways to feed your baby or toddler. And of course, don't dilute the infant formula, and don't make homemade infant formula, and don't buy formula online that comes outside the US. So these are some of the key messages we wanted to continue to share with you. Next slide, please. So some of the federal work that's going on, the White House has pulled together a number of key federal partners for discussion and for action. FDA is the key agency for action on this issue. It's closely monitoring the infant supply, and it's working with the manufacturers to help bring safe formula to market, particularly specialty formula. Engaging retail stakeholder groups to request quantity limits in order to spread on the formula purchases, and not objecting to Abbott releasing products to individuals on a case-by-case basis. Link is provided for further information. Next slide, please. As for WIC, WIC has granted additional flexibilities for states with regard to medical documentation, maximum monthly allowance, and vendor exchange. I think one of the key things that we keep referencing is the links to those that are at the heart of making decisions with regard to the shortage and this challenge in the states at this time. Next slide, please. Again, the Abbott resource for healthcare providers is there's a product order form for specialty formulas. The key here is it can only be ordered by healthcare providers, not by consumers or families, but the formula itself can be shipped to the hospital or to the patient home. So what can we do? Next slide, please. One of the things that we do is, and we have a key voice with maternal and child health populations with those moms and families in our states. We can share messages with families on how to find formula and safety tips. We can reach out to the families served under Children with Special Healthcare Need and other programs that might be using specialty formulas, collaborating with WIC and engaging pediatric providers, children's hospitals, and specialty providers. You can share the Abbott letter and order form. You can share WIC resources. And the next couple slides I have are, again, links. If we can go to the next slide and the following slide as well. These are links for you to be able to download with regard to additional resources. But I think one of the things I'd like to say in this closing minute, We want to hear from you and where you are at with the formula shortage and its challenges. That's one question. And what we can do as federal partners with FDA and with USDA to help you during this crisis. So we'll have some time at the end to do some questions and answers, but feel free if you want to put it in the chat to say where you're at or what you need at this point in time. But we realize this is a crisis that we need to be a partner in addressing. So with that, Amy, I know that was fast, 10 minutes, but by all means, I give it back to you.
Thank you so much. And actually, next slide, please. We wanted to, no, we're missing a slide. I'm sorry. Okay, so we'll go back. What we had wanted to do is actually talk to the attendees on the call and do a little poll to see how your states are being impacted by the formula shortage. If it's something that you are, I'm going to ask Lauren to pull that up. If you're seeing any impact and what state you're from, and I would love, if you want to chime in and tell us either how you're addressing it or what your needs may be. And I'll also briefly mention that the House Energy and Commerce Committee is going to be holding a hearing on this in 2 weeks. I'm sure they won't be the only ones. And it would also be really helpful if we can gather information that would be informative for that purpose, but also just so that we can also keep track amongst our members who might need more information about this, who might have come up with creative solutions. I was just talking with some colleagues on another call earlier about how the problem is right now, it seems to be a production issue, but we also want to make sure that we're getting the message out to families as much as possible. So I think we can close that out. And are we able to show the results? So, okay, well, we only had 5 people answer, and there's definitely more than 5 people on this call. But of the states that answered, can anyone share how you're feeling it or what you've been hearing from the field? Oh, I see we have some hands raised. So yes, Lynn, please feel free to unmute yourself.
Hi, Lynn Nilsson from the state of Utah. Can you guys hear me okay?
We can, thank you.
Good, yeah, so the Utah WIC program has worked very diligently with USDA and FNS and the region, the Southwest region. And we've implemented all the things, right, that, the creative ways to work around. And we've done that really well and really effectively, but the supply is just not there. And we are at a literal critical time where especially for the specialty formulas, I love the idea of having a physician contact Abbott directly, and I'm definitely going to share that with my WIC staff. But I had a conversation with Dr. Warren yesterday. I've reached out to you guys. I've sent emails and whatever, but we're at a critical turning point where my leadership is saying, what can we do, and I'm saying have all the governors call the president. And I mean, between all of us, we should, and leadership and upper leadership and legislators and whatnot, we should be able to figure this out. I'm just having a hard time understanding, because you hear rumors about what, formula being held up in customs, and you hear all sorts of rumors. I would love to know, what is the problem with that plant in Michigan, and why is it taking so long to open it back up again? Now, realizing that once it's opening and running at full capacity, there's still a distribution issue, right? And so it's is the National Guard set to be ready to go? I mean, we're kind of at that point. So that's kind of what's going on in Utah, and I'm assuming that we are not the only ones.
Thank you so much for sharing that, Lynn.
Yep, you bet.
Cheryl, I saw you have your hand up as well.
Yes, I'm Cheryl Jones from Iowa. I work with the special needs program, and this is a problem in that population. I've had moms in and they're desperate. And I'm working with our dietitians to say, okay, this is the formula they were on. What other options do we have that will meet the requirements? Well, we can find formulas, but sometimes they don't tolerate it as well, especially the others. And we're, so right now, and I was actually on a collaborative meeting this morning with our mental health well-being collaborative, which meets in 8 counties. And that was one of the questions that came up. Parents can't find formula. And I agree with the previous person. It isn't just, I mean, it's desperate. People just, and you walk in your stores, the formula county, they're empty. There is no formula. And, they're talking about limiting purchases like they did toilet paper. Parents are freaking about that. They've got people searching for formula. I mean, I'm happy as a nurse practitioner to write an order for those special things, and I've been doing it, but it's still a problem to get them. I'm just saying, and I agree, we need to, and I share the frustration too. Why in God's name is it taking this long to get that production plant back online? I know that a lot of things have to be done and it has to be safe, okay? But we can't have kids that don't have anything to eat. I mean, this is a critical thing. We can't just say, okay, give them skim milk or give them whole milk. It doesn't work that way. And God forbid we go back to some homemade formulas, which have killed babies in the past. So right now, I'm going to be talking directly to our WIC people, and I'm going to see, I'm just really becoming aware of how crucial it is with my own patient clinic load. So, but I'll be honest with you, it's panic for a lot of families. That's where they're at now. They're into panic mode because they don't know what they're going to get their next formula. They got grandparents in other states looking for stuff. I heard that this morning. So it's a crisis. There's no way around it. And if you're working with kids with special needs who really don't tolerate a lot of different formulas, it's a huge issue.
Thank you. I see in the chat, Martha says in Missouri, a lot of it is responding to erroneous social media messages about making homemade formula. And Lynn said they're going to do a media campaign and use many of the suggestions in Chris's slides. That's great. And of course, you all should have copies of the slide deck from today so that you can take that information. And I know Chris, and he'll be happy to share that with anyone directly as well.
No, I think one of the things that's so important is that, we're looking to mobilize behind the scenes and get FDA and make sure we get USDA and WIC, together to be able to coordinate and have your back on this. So we're any ideas, suggestions, or worries, we want to hear it. We want to know it. So you can always email me directly as well. And certainly anything that you share with AMCHP we're going to work partner to partner on this as well.
Thank you again, and thank you for sharing your stories just to really help hammer, in what the impact is on the families right now. All right, we still have 2 more speakers, so I'm going to move along, but feel free to keep typing in the chat. And our next speaker, next slide. Thank you, is Dr. Shannon Stokely from the National Center for Immunization and Respiratory Diseases. Shannon, you're up.
Thanks, and thanks for this opportunity to provide an update on a report we just published last month about our kindergarten vaccination coverage in the US. Next slide. So just as a reminder, this report is for the 2020-2021 school year, and a link to the report is shown at the bottom of the slide. Every year, state immunization programs report aggregated data, so it's just totals of their kindergarten population that are entering school and reporting on their vaccination status, how many children have exemptions, how many children may be attending school through a grace period or provisional enrollment, and how many children have no documentation at all about their vaccination status. There's a lot of variation across states in terms of which vaccines are required by law for school entry. There's also differences in how the states collect their information. Some do a complete census of all their schools. Some states do a survey of their schools. And so there's some different methods, but we do some adjustment to provide national estimates. Just one note on the grace period and provisional enrollment. A grace period is a situation where a child may be starting school, doesn't have any documentation, or hasn't submitted their information yet. And so they're given a period of time. It could be a couple of weeks, it could be a few months, depending on the state policy, where they can attend school while they're getting their paperwork in order. A provisional enrollment is the situation where a child doesn't have their information, or they may not be fully compliant with the school requirements, but they're in the process of getting their vaccinations completed. And as we know, with some vaccine series, there's multiple doses, and so you need a longer period to get caught up. And so they're allowed to attend school, while they're in the process of completing their vaccinations. So next slide. So this is just our high level results. What we found in the 2020-21 school year, the first thing is that we saw a decrease in enrollment of kindergarten students. And this is probably not unexpected given what was happening in 2020. Many schools were either virtual completely or in a hybrid status. So some kids at home, some kids in person. But what we found was that 400,000 fewer students were enrolled in kindergarten than what we would have expected. And what that means is we have no information on these 400,000 students. We don't have any insight into their vaccination status. For those that were attending school and that we got information for, we saw that vaccination coverage was near 94%. And this was for MMR, DTaP, and varicella. And every state has a requirement for these vaccines. This is a decrease of about 1 percentage point from the previous school year. Now, for that decrease, that translates to about 35,000 children. What we saw with respect to exemptions is that 2.2% of students had an exemption on file for one or more vaccines. Exemptions did not increase during this time period. They actually decreased in many states. So that drop in vaccination coverage that we observed, we don't think is due to vaccine hesitancy or vaccine refusal, because if it had been that, we probably would have seen an increase in exemptions. We really think that drop in coverage is due to the disruption of the pandemic and challenges with getting appointments at their doctor's office to get their vaccines that they needed for school entry. We also saw about 2% of children attending school under a grace period or provisional enrollment, and about 1% of children had no documentation at all. And that's actually a large increase from the previous year. Again, I think this is really a reflection of the impact of the pandemic and just the challenges that were occurring during 2020, especially with school enrollment and the way school was being operated during that time period. Next slide, please. So I mentioned some of this earlier, but when we talked with states, what we learned from this school year is, many schools were easing their vaccination requirements, especially for students who are doing remote learning. There was a lot of formal or informal expansion of a grace period or provisional enrollment, so allowing children to attend school while they may not be fully vaccinated. We know there was a reduced access to well-child appointments, making it difficult to obtain vaccinations. And there may have been some reluctance among parents to go to the doctor's office just because of concerns over the spread of COVID. We know there was fewer parents submitting documentation. Schools had staffing issues and may not have the staff available to follow up on vaccination histories, and also to do the assessment and reporting. And we also had to alter our data collection schedule because of the pandemic and because programs and schools were having to deal with higher priority activities, with the rollout of managing the pandemic and then also preparing for the COVID vaccine. Next slide. So although, in general, vaccination coverage levels are high, they're 94%, But anytime we have a decrease in vaccination coverage, you know, we are always concerned because we want children to be up to date with their vaccines. And so we are, you know, been talking with partners and other stakeholders with our call to action, you know, to remind parents to get their kids caught up on routine vaccinations. We've been encouraging providers to do what we call reminder recall, you know, going through their records, identifying who of their patients may have missed doses and contacting them to schedule appointments and to get them back in the office. Also, if they have EHR systems or other systems in place in their office, to do prompts so that when a patient is in the office, they review their vaccination history and then recommend vaccination if it's necessary. And then also letting parents know about the precautions in place for safe delivery of services. And then we're also promoting with schools to follow up with families who are not in compliance with requirements. And also now that some families may be enrolling their children for the next school year, you know, to remind them of what the requirements are and you know, letting them know of services available in order to get their kids caught up on vaccination. And just one other note that our 2021-2022 school year report will be coming out later this year in November. So we'll be monitoring to see if this drop in coverage was just, you know, a one-year thing or if it's continuing and additional activity will be needed. So thank you.
Thank you so much. Do we have any questions at this time? And I will actually encourage you all to put those in the chat right now. Maybe we can do a full Q&A at the end because we only have a few minutes left. And I'm going to turn it over to Allison for a policy update from AMCHP.
Thanks, Amy. Hi, everybody. It's great to be with you this afternoon. Next slide, please. We didn't have our April call, so I have a few catch-up calls that I'll go through pretty quickly just to make sure everybody is up to date, but I can get through these pretty quickly. So the end of March was a busy time for appropriations. Congress passed and the president signed into law the final FY22 appropriations bill, which of course included funding as appropriations bills do, and included a $35 million increase for the block grant. This was not as high as the standalone bills in the House and Senate had been. We'd seen some pretty transformational proposed increases to the block grant. $35 million increase is nothing to sneeze at, though. The top line numbers for that final bill ended up being lower than everyone hoped, and so many programs received level funding or just $1 million or $2 million plus up. So we ultimately were pleased with where the final number ended up for the block grant. I do want to note, though, that most of the increase went to the SPRANS line. About $5 million went to the state formula fund, and I'm going to touch on that a bit in a couple of minutes. Also of note, 2 authorizing bills were included in the FY22 appropriations bill. And so these are not funding, these are new statutes. So the Maternal Health Quality Improvement Act and the Rural Moms Act, these are 2 bills that AMCHP has worked on for many years, that many maternal health stakeholders have worked on, that would authorize new programs or codify existing programs like the Alliance for Innovation on Maternal Health and the Our Moms program. You can check out the AMCHP Maternal Health Bill Tracker for more details on those bills, but just wanted to note that. And also our legislative alert has more details about the funding levels. Next slide, please. Okay, also at the end of March, we had the FY23 President's Budget Request. And in terms of the block grant request, this is the highest level, to my knowledge, and I think that's accurate, that we have ever seen a president request for the Title V block grant, above the authorized level of $850 million. The request is for $953.7 million. That would be an over $200 million increase above the FY22 level. Again, the majority of that would go to the SPRANS line, and actually several sublines of special projects of regional and national significance, many of which are focused on improving maternal health and specifically targeting inequities in maternal health outcomes based on race, ethnicity, and geography. And there's more information on a separate legislative alert that you can link to from the slides. Next slide, please. Okay, so AMCHP asks, as a reminder, this fiscal year FY23, we're urging Congress to provide $1 billion for the Title V Block Grant. This is, again, the biggest ask that AMCHP has ever made for the Block Grant. We're pushing for it really hard. And as part of that ask, that request for funding, we are emphasizing the need to provide robust increases for the state formula fund. We support grants funding, we know that you do too, but we're really making the case that we need to invest in the core public health infrastructure, the state formula fund that's going to all states and territories. And for that to make a difference, it has to be a meaningful increase. It can't just be, 2 million divided by 59. So really pushing for that kind of transformational increase this year. We've also put in specific requests for 2 funding lines at CDC, $164 million at the Division of Reproductive Health that funds things like the state maternal mortality review committees and perinatal quality collaboratives. This is aligned with the president's budget request for this funding line. And then $100 million for CDC's Surveillance for Emerging Threats to Mothers and Babies Network, or SETNet program. Next slide, please. This is a quick screen grab of the Friends of Title V letter that AMCHP leads each year. And this year we had 108 national organizations join us as co-signers in support of the $1 billion ask for the Title V Block Grant. The letter also again makes clear the importance of robust funding for the state formula fund. You can view that letter via this link on our website. Next slide, please. We supported these 5 member-led Dear Colleague letters. These are letters sent by members of Congress and senators to their colleagues in the House and Senate in support of key maternal and child health programs. The House and Senate maternal health letter highlights Title V, Healthy Start, CDC Safe Motherhood, and the National Institute for Child Health and Human Development. 2 letters, House and Senate, in support of SETNet, and then a new letter in support of those bills I mentioned that passed as part of the omnibus, the Maternal Health Quality Improvement Act and Rural Moms Act. Next slide, please. There's some maternal health legislation moving in both the House and Senate side. You can click here for more information in the slide deck. Next slide, please. And then last, I wanted to share, you should have all received this via email from AMCHP, but in response to the news last week that leaked draft majority opinion in the Dobbs v. Jackson case, AMCHP CEO Terrence Moore released a statement that really underscores our organizational commitment to racial equity and health equity, and that we see the upending of Roe v. Wade as a direct assault on those important tenets. And I encourage you to read the statement if you haven't already. And I'd also encourage folks to follow SCOTUS blog for really timely and informative updates on all Supreme Court cases. Next slide, please. And we have 2 minutes for Q&A. Amy, I'll hand it back to you.
Thanks, Allison. Well, we do have 2 minutes. So if anybody has anything they want to add, this is the time to do that. Next slide, please. Just a reminder that our next call will be on June 9th. And if you hadn't previously registered for this series of calls, please do so. And we'll give you all another minute or 2 if you have any questions. Martha had a great suggestion. If there's a standardized media campaign or resources that could be provided to all states and territories for message consistency, that's back on the formula issue. Chris, I don't know if anything is in the works at HHS for that.
I don't know right now, but it is a great suggestion, and I'm going to do some investigation, and we'll figure that out. I think it's a great way to move forward.
Amy?
Yes.
This is Terrence. Hi, everybody. I just wanted to make a quick plug as well from Allison's comments around our sort of unprecedented ask in terms of appropriations for FY23 and beyond. We really are eager to hear from states and jurisdictions about what increases in your formula funds would look like. What would you support at a much more sort of increased level. And so we're excited to get examples from the field that we can share on our visits. So would love to sort of put that on your mental lobes now to start thinking about, particularly as we launch to our conference next week. So that's my second point is, if you haven't registered for the conference already, we really hope that folks will, and we're excited to see you virtually in a couple weeks.
Great. Thank you so much, Terrence, for jumping in. Somebody put something in the chat. Oh, Allison put something in the chat with the link. And with that, we're going to say goodbye. You want to say goodbye? Bye. And we will see you next month. Thank you, everyone.